Well, good afternoon, folks. My name is John Burns. I am Vice President of Audit Compliance with Arch Pro Coding. I'd like to welcome you to today's program. As we all know, this is related to coding and reporting coronavirus-related services during the COVID-19 pandemic. I've recently updated the numbers, but obviously some of the numbers in this program, in the slide deck, they continue to change. So this presentation has evolved over the past couple of months. I certainly hope that I hope today finds everyone doing well. We do have about 52 people in well, 53 now. We're expecting just over 100. So I know that we'll get some people. If there are any technical difficulties that anyone has whatsoever, you can use the chat box and send a private message. You can send it to everyone if you choose, but send a message through the chat box to Julia Scott, and she'll be online with us over the next 45 minutes to an hour as we go through this webinar. I'm also going to ask that you use that chat box for any kind of questions you may have as we move along here, and I'll be making some references to that chat box as we kind of push through the program, and that way we don't have to save all the questions until the end of the program. We can actually try to incorporate and address some of those throughout. So I hope that made sense. For those of you that don't know how to find the chat box, there is a toolbar. And at the far right-hand side of that toolbar, you'll see the word more with 3 dots above it. If you click on that, you'll see that the chat option is right at the top of that particular piece of the menu. So again, let's use the chat box for questions you may have. We're going to keep everyone paused out just to make sure that we stay on course. I've already done a sound check. I think that we've confirmed that everyone can hear me all right. Again, Julia Scott, you can, excuse me, you can individually and privately message her if there are any technical difficulties whatsoever, if you can't hear audio or you can't see the presentation. If there's something technologically that isn't working out for you, by all means, she'll be happy to coach you through it. This program is being made possible through the Montana Flex program and also the Montana Office for Rural Health. We certainly appreciate the opportunity for being here. The program is worth 1 continuing education unit, 1 CEU hour. It will be provided to you via email, probably by day's end, close of business tomorrow. Once we have everyone who actually is in attendance here today, Julia Scott will be sending out that CEU certificate afterwards. And one more thing, for those of you that are on social media, like it seems everyone else is, please, by all means, go and like us on our Facebook page. And that's one way that we kind of keep all of our clients engaged and up to date with a lot of things as they change. We all know that what we're talking about here this afternoon, the guidance that we've been provided has continued to change and evolve since this whole pandemic even started. So I'm going to try to stay on point. I don't know, we don't really have any time constraints. I know that we'll be done certainly within the hour here. But again, if you have any questions, use that chat box and I will try to address those throughout the program. So I'm just going to open that chat box now, see if there's anybody. All right, nothing yet. So let's go ahead and get started. Again, you know who I am. I've got a couple of disclosures that I need to make before we can actually, before we can move on. First, the contents of this program are copyrighted by the Association for Rural and Community Health Professional Coding, that is Arch Pro Coding, and cannot be used, recreated, reproduced, or disseminated in any other way without the written consent of Arch Pro Coding. Also, there's going to be a number of references that I'm going to make over the next hour-ish to 2020 CPT, which we know is authored by the American Medical Association. All of the codes, the symbols, the definitions, the nomenclature, they're all copyrighted and owned by the American Medical Association. And of course, Arch Pro Coding does not claim any ownership or authorship of that content. All rights are reserved, and we clearly are going to be using the AMA's codes. And as we talk about them, they will be for instructional purposes only. I don't have to make that same disclosure as it relates to HCPCS Level 2 codes or ICD-10 codes, because obviously they are not protected by such copyright laws. So now that I've made those content disclosures, we can go ahead and move on. What we want to make sure we do throughout the presentation today is discuss specifically how the COVID-19 public health emergency or pandemic, how it impacts us from clinical documentation perspectives and also from coding and billing perspectives. I wish I had $1 for every question that I've seen come over, whether it be a list serve that I'm actively, that I actively participate in. I guess the point that I'm making is I've seen a lot of misinformation out there, and I truly think that everyone is doing their best to give people timely information that's accurate and precise. But as these rules and these, and the guidance that we're provided continues to change, we have to keep our eyes open and understand that different payers may have different reporting criteria. So, for example, we're going to talk about Medicare, and I'm going to focus from the rural health perspective. So, we're going to talk about the appropriate way to report COVID-19 related services during this public health emergency to Medicare from RHCs, FQHCs, and of course, critical access hospitals. Excuse me. For commercial plans, for each state-specific Medicaid program, it's important that we understand exactly what their reporting requirements are, because they may change from plan to plan and from state to state. We have to focus on the CPT, the HCPCS Level 2, and the ICD-10 codes that relate to COVID-19. And again, I've never really seen codes that have actually been put together in an emergent fashion the way that it has in this particular or during this time. I've never seen the AMA respond by creating a CPT code as quickly as they did this year as it relates to COVID testing. We have to talk a little bit about modifiers as well. There are some modifiers such as 95. Now, the modifiers in CPT, for those of you that aren't really familiar with using CPT, where you'll find those is in the index. It's actually Appendix A, towards the back of the AMA's CPT manual. And when you look at modifier 95, it is specific to synchronous real-time audio and visual technology that's utilized for the rendering of telehealth services, or I should say telemedicine. And there is a difference between telemedicine and telehealth. Again, I think that's something that not everyone is aware of. A lot of people try to use those two words interchangeably and synonymously, and they're not. They are unique. Telehealth is one aspect of telemedicine, but telemedicine carries other things like virtual check-in visits and things like that that we'll also discuss here a little bit today. The CG modifier, for those of you that may be representing an FQHC, we're never going to suggest that you use the CG modifier. That's only intended for RHC claims. However, the CS modifier is a modifier that relates in all of those settings as it relates to COVID testing. In other words, visits that are related to or result in testing for COVID-related symptoms. The CS modifier is utilized literally to waive Medicare's cost-sharing requirements. So a patient's coinsurance or deductible, if applicable, would not apply in cases where the CS modifier is utilized. The differences between telehealth visits, virtual check-in visits, and EVisits. Now, again, this is something that just a few weeks ago, we were provided guidance. I believe it was back on April the 30th. So it was just about, let's call it 5-6 weeks ago. The virtual check-ins were actually being reported using G0071. Well, now virtual check-ins, even if there's audio-only services being performed, the way that RHCs and FQHCs are going to be reporting these services to Medicare is with the use of another HCPCS Level 2 code that was created back in April, and that is G2025. We'll talk a little bit more about that in a bit. Now, EVisits are different. Again, this is a subsection or a subset of codes that relate to telemedicine, but not specifically telehealth. EVisits are where there are actual patient portals that are being utilized. There's not a telephone call. It's basically an electronic portal that patient has access to, but it's not real time. And anytime we're not talking about real-time synchronous audio and visual technology being utilized, that modifier 95 is off the table. Don't need to use it. In fact, I would strongly suggest we don't use it in those cases. The Coronavirus Aid, Relief, and Economic Security Act, the CARES Act is what we call it. We have to talk about that a little bit because with it came waivers, and with it came the ability for RHCs and FQHCs to actually qualify as distant site providers during the public health crisis. And that's really unique because as many of us on the line here know, oftentimes, not even oftentimes, prior to any of this COVID-19 pandemic, coming to our doorsteps, rural health clinics and federally qualified health centers could only qualify as the originating sites, which is essentially where the patient is. And the distant site is not something that was permitted. Well, with the waivers, and with the CARES Act comes telehealth services that can be provided by any licensed practitioner working within their scope of practice with no restrictions on where that provider is or where the patient is. Patient may be at their home, provider may even be at their home. And the visits are actually reported just as though they'd be reported if the patient had a face-to-face visit in the clinic or health center. And toward the end of the program, I think it's the second to last slide. The last slide, obviously, I provide you resources that I utilize to obtain the information that you'll see throughout the course of this PowerPoint presentation. But the second to last slide is just a resources page. And what you can do is actually use those active hyperlinks to access anything, to include the current list of approved telehealth services recognized by Medicare. Now, you may ask, why is that important? Well, for RHCs and FQHCs who actually participate in telehealth, any of those approved services right now, you'll notice that, and if you use the link, you'll actually find that it's nothing more than a glamorized Excel spreadsheet. And within that Excel spreadsheet, you'll see where there's actually a column on the far right-hand side that actually says during COVID-19 pandemic, which means that code qualifies for telehealth now. But once the public health emergency is lifted and the COVID-19 pandemic has run its course, and none of us have a crystal ball and know exactly when that's going to be, but when that happens, I'll guarantee you that that list of approved telehealth services will probably evolve. And some of those things that are approved for telemedicine or telehealth now may not be later. So I hope that made sense. The second to last slide is just a list of, I think, very valuable links that you'll be able to use after this program in order to further research and obviously feed your brains with coding related things related to COVID-19. So let's just talk about some of the figures here. And again, this doesn't really have much to do with coding, but if we just think about the complexity of the environment that we're in now, we look at more than 1.8 million cases of COVID-19 known of in the United States as of just day before yesterday, June the 2nd. More than almost 6.5 million cases worldwide. We've surpassed that 100,000 death mark here in the United States. It's been reported in all 50 states, more than 210 countries and territories around the world. And this was issued as a public health or as a national emergency by President Trump back on March 13th. And on March 27th, the CARES Act became finalized. And with that came Section 3704, authorizing RHCs and FQHCs to qualify for distant site purposes when reporting telehealth services. The billing and the coding guidance that we've all received, it continues to change and be modified. And like I said earlier, there's actually, you could ask 5 people the same question, and sometimes you may wind up with 5 different answers. I'm going to try not to do that. And obviously, like I said, I'll continue to check this chat box to see if there are any questions that you may have throughout the course of the program that I can try to address. For those of you that have a little piece of paper and a pen next to you, if you wanted to jot down my email address, it is simply jburns, that's JBURNS, at archprocoding.com. You can reach out to me directly if you see fit after the program. If there's something that you feel I might be able to help you out with even more. And the last major coding changes and clarification that we received was through that Medicare Learning Network SE 20016. It was revised back on April the 30th. There is a link that I have to that document on that previously mentioned resource page toward the end of the presentation. So one thing that we all know is telehealth has certainly been expanded. Our ability to utilize telehealth has been expanded considerably during this public health crisis. So Medicare telehealth coverage, including even those that are not related to COVID-19. In other words, there are folks that are actually performing annual wellness visits, for example. Now think about that, annual wellness visits, that's one thing, but there may be certain aspects of a visit. Think about a physical exam that through telemedicine and through telehealth may not actually be, it may not be possible. I mean, let's face it, if a provider is on an audio only device with a patient, which is still reportable with that G2025 that I mentioned a little while ago, it's not like the provider over the telephone can actually provide a physical exam. So there are certain restrictions that have been lifted during this time. So I hope that makes sense. If you look down to the third bullet on this slide, again, originating versus distant site. These are two really, really important terms as it relates to telehealth. The originating site is where that eligible Medicare beneficiary is during the telehealth service, whereas the distant site is actually where the practitioner is. Now, prior to this public health emergency, FQHCs and RHCs could only qualify as the originating sites, but all that was lifted. And again, Section 1135 offers for expansion waivers, allowing for increased use of telehealth services, specifically, certainly in RHCs and FQHCs, including evaluation and management services, mental health services and counseling, and preventive health screenings as well. So it's not the beneficiary's diagnosis that needs to be related to COVID-19 that would allow for telehealth to be utilized. Telemedicine, and specifically telehealth, can be utilized right now for any diagnosis, for any patients following up with chronic conditions or what have you. It's not just related to COVID-related matters. So let's move on. Oftentimes, and for those of you that may have met me in the past, you've probably heard me harp on Chapter 9 of the Medicare Policy Manual and Chapter 13 of the Medicare Benefits Policy Manual. And what those chapters are is they are chapters with regards to documenting, coding, billing, appropriate locations, covered services, but specifically for RHCs and FQHCs. Chapter 9 of the manual specifically stated that RHCs and FQHCs may bill as originating sites only. Again, that is not the case during the COVID-19 public health emergency. But let's face it, and this is a question that we've gotten a number of times. People have asked, when this public health crisis has finally run its course, will RHCs and FQHCs continue to be able to report telehealth services as distant site providers? And frankly, the answer is we don't know. I do have some suspicions that I'm not going to share with you because I don't want to be held accountable to them, to be honest. I have my suspicions, but we just don't know. And we're going to have to keep our eyes on that bouncing ball until that ball comes to a stop, and we'll all be watching that ball together. So effective on March 16th, the Coronavirus Preparedness and Response Supplemental Appropriations Act, HHS was given the authority to waive certain telehealth requirements. With that came the ability for FQHCs and RHCs to qualify as distant sites, and also Medicare beneficiaries would be entitled to receive these telehealth services in all settings. So it wouldn't just be if they were in some rural area somewhere. These are actually services that can be used all over. There is no, let's just say that there's no locality requirement, if you will. Another waiver that is allowed through Section 1135, subsection B, it allows for the use of telephones and things with video and audio capabilities such as Skype and FaceTime. These types of technology can actually be utilized during this time, in order to deliver telehealth services. The Office of Civil Rights has also relaxed requirements as they relate to the Health Insurance Portability and Accountability Act. That, of course, is what we refer to as HIPAA. So during this time, there are certain elements of certain pieces of technology that may not have the types of encryption and the types of privacy provisions that other other things do. So if you're using Zoom, for example, or if you're on Google Meet or whatever it may very well be, there may not be security measures in that particular technology that would be covered or that would be acceptable under HIPAA. But during this COVID-19 public health emergency or pandemic, I'll start calling it a pandemic from here on out. During this time, the Office of Civil Rights has relaxed those restrictions and has allowed that type of technology to be utilized without worry of HIPAA privacy violations. And all of this is going to remain in effect until the public health emergency is ended. And again, I can't even pretend for a moment, for a moment to know exactly when that's going to be. Now, depending on, where we are, I'm in upstate New York, and I know that, there are various parts of the states that are in phase 1 and phase 2 and coming into phase 3 of reopening, if you will. So things are starting to get back to something maybe close to normal for some of us in some places, but it's certainly not ended, and we don't know if a second wave will come. We don't know what the fall and flu season may bring, how it may complicate the COVID-19 pandemic. It's just something that we have to keep our eyes on. But again, all of this is going to remain in effect until the public health emergency has been lifted. So here's some of the latest news and updates that we need to get to. Now, before I go to it, I see that we've got some things here in the chat box. I'm just going to try to see what questions we have in here. Okay, they weren't questions. All right, that was just Julia reaching out to some of you all. All right, so payment for distant site telehealth services. It's been set at $92.03. Okay, this represents the average or the median amount for all covered and approved telehealth services. So that's where that number really came from. Distant site services that were provided between January 27 and continue through June 30th will require modifier 95 for synchronous, and like I mentioned earlier, the real-time audio and video telecommunication capabilities. But come July 1st, the use of modifier 95 will be optional, okay? The CG modifier is still required on RHC claims during this time. RHCs and FQHCs, you'll continue to be paid your all-inclusive rate or the PPS, the prospective payment system rate, respectively. And the claims will simply be reprocessed if necessary in July. In other words, it is $92.03. It may actually need to be reconciled down the line. And we've been led to believe that no one's going to need to resubmit anything in terms of claiming that $92.03. That's something that we're under the impression is just going to, that's supposed to just happen. All right. In red, fourth bullet, from July 1, 2020 through the end of this public health emergency, RHCs and FQHCs are now to be reporting G2025. And that's specifically used for telehealth services during the COVID-19 pandemic. It also includes audio-only services. So what we found with a lot of our clients is that they're continuing to utilize that G0071 that was being used for virtual check-in services. Medicare has made it very, very clear that audio-only capability, those services can also be reported using that G2025 during this public health emergency. The costs for telehealth services must be captured on the annual cost report. So for the RHCs out there, you can see that it's on the CMS form 222-17, line 79 of worksheet A. And for FQHCs, it's CMS form 224-14, line 66 of worksheet A on that particular cost reporting document. And then the modifier CS, like I previously mentioned, it's to be utilized by all FQHCs and RHCs to waive any patient cost sharing, such as coinsurance, for any COVID-19 testing related services or services that relate to or result in COVID-19 testing. This is just something that comes from the CARES Act, but again, I wanted to provide it to you. All it is directly from the horse's mouth in section 1834, subsection M. It just basically says that FQHCs and RHCs, they can serve as distant site providers during this public health emergency. Will that be the case later on down the road? Again, we just don't know. We'll have to wait and see. If I had a crystal ball, I'd be able to tell you. So let's talk about billing, all right? Billing and payment, okay? During this, during the COVID-19 public health emergency, NP's supervision requirements have been relaxed as well. So there's always been this need they be there a minimum of 50% of the time that the clinic's open. That's no longer a provision. That's not necessary during this particular time. There is still the HCPCS Level 2 code Q3014, but it's only to be utilized for originating site services. So that would basically mean that you're using telehealth, but you are the originating site and the patient is actually there on site, but the consulting provider, the distant site provider, is somewhere else. That code still exists, but we're really focusing now on distant site reporting, which seems to be the case for most of us at this time. For distant site services provided between July 1 and the end of the COVID-19 public health emergency, FQHCs and RHCs will continue to use G2025. That's the instruction we've been led, that we've come to understand so far. Could that change? Sure, it could. We don't anticipate that changing. And when will the end of that COVID-19, public health emergency end? Again, we simply don't know. So until that time, we will be reporting G2025. There were a lot of folks up to about a couple of weeks ago. I think it's been clarified, multiple times by CMS and on multiple listservs that I'm a part of. But the G2025 was a code that was it was actually, many people were under the impression that it was a code that had been created but was not to be reported until July 1. That's not the case. It actually is to be reported now and throughout the balance of this public health emergency. So G2025 is very much alive and well, and that is the code that we should be utilizing for both virtual communication services and, for telehealth services during the COVID-19 public health emergency. The payment rate, once again, for distance site telehealth is set at $92.03, and the modifier CS is used to waive patient cost sharing. I mentioned earlier there is a list of covered telehealth services. The hyperlink you'll see on the bottom of this slide, that's what it's intended to do, is to provide you with a snapshot of all of the services that right now are approved and covered when using telehealth. But again, once this public health emergency is lifted, I do firmly believe that this list of approved telemedicine services and telehealth services is probably going to change as a result. But again, we'll just have to kind of wait and see. What you're looking at here is just a list of COVID-19 related testing codes. And as you can see, the first 4 of them, these are U codes, U0001, 2, 3, and 4, okay? Now you'll notice that the first, let's see here. Yeah, you'll notice that the U0001 is for a CDC COVID-19 test, okay? And you can see here that the U0002 is, if you look at the base or the conclusion of that definition, that's a non-CDC test. I mentioned earlier in the program that I've never really seen the AMA respond to a need for a code so quickly. So when you look at those codes 87635, 86769, and 86328, those specifically are for tests where the AMA has created codes in response to the COVID-19 crisis. So again, I've just never really seen codes created so expeditiously. Same thing with the diagnostic code that I'll share with you just in just a few minutes. The diagnostic code that now is reported is not what we had to report back in February and March. The World Health Organization actually emergently created a code. If you wanted to jot it down, we'll reference it again later. It's U07.1, but that is specifically for the diagnosis of novel coronavirus, or what we like to call, or what has been abbreviated and called COVID-19. This is a bit of a redundant slide to the last, okay? But this is full definitions of each of these codes and the time frame in which they were released. So you can see that it wasn't until April that we got those CDC and non-CDC testing codes, the U codes. You can see it was March when the CPT came out with its first CPT code as it relates to COVID-19, and followed up in April with 2 more. So again, a very, very quick response from the American Medical Association in creating codes for reporting purposes during the COVID-19 pandemic. So I mentioned earlier that telemedicine and telehealth shouldn't be confused. Frankly, I make the same mistake from time to time. I certainly don't try to, but telemedicine has with it a series of, or a subset of services. So under telemedicine, the first thing that we can talk about are telehealth visits. The ones that most of you are probably most familiar with. Now you'll notice that the codes 99201 and 99211, those are the lowest level evaluation and management services for established patients or for new patients and established patients specifically. 99211 and 99201 are actually currently listed on the approved list of telehealth services, which means they're fair game. It means that they are reportable during this time using G2025. So certainly something to be aware of. You can see there are some G codes that you'll see there as well. HCPCS Level 2 codes always start with alpha characters because they're created by the federal government, the Centers for Medicare and Medicaid Services. But those are specific codes for consults and emergency department and initial inpatient visits and consults and hospitals and skilled nursing facilities. The last bullet in this particular set of codes, the telehealth visits, is a reference to Appendix P as in Paul. And that's, again, almost all the way in the back of CPT. You'll see a list of all those codes that actually require or that are approved for telehealth with real live audio, synchronous audio and visual telecommunication capabilities. The modifier to be utilized in those cases is 95. And you'll find an Appendix P that lists all of those services that the AMA claims are reportable as telehealth. Virtual check-in. Now again, this may very well be, and again, it's typically supposed to take 5 minutes, a minimum of 5 minutes. But patients in their home, they might have brief communications with practitioners. And as long as those practitioners, regardless of what their title is, if they are working within the scope of their practice in their particular state, that will allow them to report the virtual check-in no longer as G0071, like was the case back in March, but as G2025. That actually qualifies. But here the modifier 95 is not required. In fact, I would say it's not permissible. And the reason I say that is because the modifier 95, remember, is only utilized when synchronous real-time audio and video technology capabilities are being employed. Now, neither of these types of telemedicine services, being telehealth visits and virtual check-in, neither of these should be confused with what we refer to as EVisits. Okay, so there are EVisits, communication with patients using a patient portal, an electronic portal. Okay, and obviously this is typically billed to Medicare Part B, where they pay a fee-for-service rate for these services, but they're 99421 through 99423. And those are still to be reported, not as G2025 as telehealth, but as EVisits, because the patient portal is being utilized and there's not that real-time communication with the practitioner or the patient. We are still limited for EVisits to G0071 during the COVID-19 pandemic. So, and again, this is going to be a little redundant, but for those of you in the RHCs out there, definitely pay attention because some of the reporting is actually going to change. What you're required to do now is not going to be the same as what's required come July 1 of 2020. Just believe it or not, a few weeks from now, which I'm still having a hard time getting my arms around that. So from January 27th of this year through January 30th, all approved distant site telehealth services for RHCs and FQHCs, they will be reported as G2025. You may want to consider modifier 95 if real-time, synchronous, that's the keyword, synchronous, real-time audio and video telecommunication capabilities are utilized. That's where 95 modifier comes into play. RHCs will still be required to consider the CG modifier. And the CS modifier, remember, that's the modifier that's utilized in order to waive patient cost sharing, being coinsurance and deductibles, if applicable. The CS modifier basically waives that patient cost sharing, and the patient is not responsible, as they would be in a non-COVID related situation. Modifier 95, as of July 1, will become optional when reporting G2025. You can use it. Don't use it. I don't think that there will be any ramification whatsoever. At least that's the impression that we've been under. I know that many of you have probably started, picking back up and performing annual wellness visits for your patients. There isn't really perfect guidance on how this is to be reported. And I know that every electronic, health record, every electronic medical record system is different. They have different bells and whistles. There are some folks and some clients that we've worked with that actually have the ability to, it's almost like in the background, the system is maintaining those codes, but it's not like we're going to be reporting the annual wellness visit code. If it's done via telehealth, we'd have to report the G2025. So for tracking purposes, it's let's just say it's not perfect. So you have a couple of different options. I know that there are some that are actually just holding off on their annual wellness visits. and trying to wait until the public health emergency has been lifted in order to do so, I'm not making that recommendation. I just know that there are certain folks doing that. And then, others that are continuing to report G2025, but having a mechanism that actually allows you to track those things internally. All right. Now, there's a couple of sub bullets here that I want to talk about closely. Okay. We're not using the CS modifier for an annual wellness visit because, of course, it's not a COVID-19 related service. In most cases, it wouldn't be. All right. And for aspects that cannot be captured, for example, like the physical exam. I mean, it's not like a doc or a provider is going to be able to palpate the heart and lungs over the phone. You know what I mean? So what has been suggested, I think this comes from National Government Services, one of our larger Medicare carriers out there, one of the MACs out there, is to document unable to capture due to public health emergency, or possibly, let's say the patient tells you what their blood pressure is or what their weight is or what have you, you can simply state something as, along the lines of as reported by the patient. And the last bullet on this slide, believe me, it frustrates me as much as it does you, but we don't have just one set of rules that are going to apply for everybody all the time. For commercial plans and for Medicaid, we're going to have to reach out to those plans specifically to see what their reporting requirements are. Is it true that Medicare they kind of set the trend typically? Yes, they set the trend, but just because Medicare says use G2025, of course, you report G2025 to some commercial health plan out there, and most likely I don't want to say I'll guarantee you, but I'm reasonably certain that you probably see a denial for that particular claim. So again, it's important that we understand what our carriers want. The purpose of this program is to really focus from a Medicare perspective. Here are some modifiers. We've already talked about them, but again, never will you use modifier 95. Never will you use that if synchronous real-time audio and video capabilities are not available. So if it's audio only, you'll never report modifier 95. The CS modifier was literally designed to eliminate patients' cost sharing and went into effect retrospectively or retroactively back to the 18th of March. Okay. And then the last here just has to do, I don't know how many critical access hospitals we have represented on the line here, but for those critical access hospitals that are utilizing what's referred to as method 2 billing methodologies, that actually would require folks in those settings to use the GT modifier, but only for critical access hospitals using method 2 billing. We mentioned virtual communication services just a little while ago, and effective January 1 of last year, FQHCs and RHCs can receive payment for virtual communication services. But the medical discussion and the remote evaluation is for a condition that's not related to a service that was provided in the previous 7 days and doesn't lead to an appointment with that patient in the next 24 hours or at the soonest or next available appointment. Now, with that said, the G2025 does not have this 7-day or 24-hour provision built into it. And I'm just saying that the G2025, hopefully we are reporting it no more frequently than once every 7 days, but the G2025, it is not a code that has that limitation, that frequency limitation on it. For FQHCs and RHCs, we have to use G2025 for telephone-only services too. Those are the CPT codes that many of us are aware of, being 99441, 442, and 443. And I think I've got a slide with those codes a little bit more specifically that I'll show you in just a moment. Now, the payment for these services is set at the non-facility fee-for-service rate, the aggregate, the average for G2012 and G2010, remote evaluation services and communication technology-based services. Those two G codes, they're not reported in FQHCs and RHCs for telehealth, but the payment for virtual communication is actually something that comes. I think I just got a question in here, so let me jump in. Okay. A question from Carrie. It says, does modifier CS also apply to critical access hospitals to waive cost sharing? As I understand it, Carrie, the answer to that question is yes. Tessa, I hope I said that right. Modifier CS, do we use modifier CS on COVID antibody testing? Yes, because obviously for that testing, patient would not be responsible for any coinsurance any cost sharing. So again, I think the CS modifier would actually apply in both those cases. Good question. We'll move on. So here are those codes for the EVisits that I mentioned more specifically. Medicare Part B pays for EVisits, but this is when we're talking about a patient portal. The use of a patient portal. It's not a real-time communication, okay? It's something where the patient uses a portal and there is essentially an electronic transfer of information between the patient and the provider, but it is not a real-time, event. So the codes are 99421, 22, and 23, and you can see that the only real difference between these codes is the fact that the codes require a set amount of time. So how would you report an e-visit of less than 5 minutes? Frankly, I would say it's not reportable because we can clearly see what the CPT definitions for those codes are. During the public health emergency, the e-visits are to be reported to Medicare using G0071, and it's paid at the 2020 calendar year 2020 rate of $13.53, okay? And you can get more information on that because the rate actually is increased to nearly $25. I don't have the exact date, but the hyperlink that you see here will take you back to a document that was provided by I think it was a MedLearn, I think that it was a MedLearn release, maybe it was mid to late, I think it was late March, maybe early April. But again, the payment was set at $13.53. That payment has actually been increased for G0071 to nearly $25. Okay. Before I get into diagnostic coding as it relates to this, I'm going to get into the chat box. I think we've got a couple more folks. Medicare updated the FQHC, stated that we're being added to the list of approved telehealth. Can FQHCs bill those under? Okay, so Annie Harris had a question. And it looks like everyone can see this in their chat box if they chose. It says Medicare updated their frequently asked questions back on the 2nd of June and stated that codes 98966 and 98968, they're being added to the approved list of telehealth services. And I appreciate that because honestly, Annie, I wasn't even aware of that yet. I haven't looked at that list specifically in probably about a week. So the question is, will FQHCs be able to bill those using G2025? And the answer is yes. And the reason the answer is yes is because we have been informed that during the COVID-19 pandemic, all approved telehealth services for FQHCs and RHCs should be reported using G2025 and will be paid at $92.03. So it's a great question, and the answer is yes, absolutely. Danielle had a question. We are a critical access hospital that does use method 2 billing. If an appointment is a rule-out COVID patient, is it appropriate to report the CS modifier on professional charges until the test returns negative? It's a great question, Danielle. I've seen this thing kicked around, and I've seen multiple answers to it. I'm going to say that if the patient has symptomology that is suspicious of or suggestive to a patient being positive for COVID-19, I think that the CS modifier in that case would be applicable. However, if it's being done as something on a purely screening basis and there is no symptomology whatsoever, I think that the CS modifier in those cases, it's a fantastic question. I've heard all sorts of different responses to it. I would say if it is COVID related based on signs or symptoms, I'd say the CS modifier would be applicable. If there are no symptoms and it's purely being done preventively and from a screening perspective, I don't think that the CS modifier would be appropriate. Great question though. You're welcome. Okay, so we can shift our attention now to diagnostic coding parameters, okay? ICD-10 codes, first and foremost, only code confirmed cases. I think that makes sense because quite frankly, we never want to give a patient something they might not have, right? So if it is confirmed, it will be reported using U07.1. That is a new diagnostic code, which is for 2019 novel coronavirus acute respiratory disease. That's the actual full definition of that code that the World Health Organization integrated and basically put in on an emergency basis just about a month ago. Sequencing will always require that the COVID be the principal diagnosis. So if the patient has an underlying condition such as diabetes or asthma or respiratory syndrome or whatever it may be, those are actually coded as secondary to the COVID diagnosis. So COVID will take that principal position in the event that it is indeed positive. And a presumptive positive test is to be coded as a confirmed test, because remember what presumptive positive really means. And you can see it's a test. It basically means that the individual is tested positive for the virus at the state or the local level, but it has not yet been confirmed by the CDC. That's all that really means. So a couple of examples here that may help and make sense for you. For pneumonia that is due to COVID-19, we're going to assign U07.1. There's the principal diagnosis. And the secondary or supportive diagnosis in that case would be J12.89 for other viral pneumonia. A couple other examples you'll see here. For acute bronchitis due to COVID-19, we would again utilize the same principal diagnosis of U07.1 for the COVID-19, but then J22 would follow as a secondary diagnosis specifying the acute lower respiratory infection. Same thing here would apply for acute respiratory distress syndrome. COVID-19, if tested positive, is still going to be placed in the primary position, but J80 for the ARDS or acute respiratory distress syndrome, that would simply be placed in the secondary position. I already mentioned this, and I'm sorry to be redundant. We're only going to code for confirmed cases. For possible exposure with the disease being ruled out, the proper or appropriate diagnostic code to report in those cases would be Z03.818, which is encounter for observation for suspected exposure to other biological agents that have been ruled out. But for patients who've actually been exposed to COVID-19, we will report Z20.828 for contact with and suspected exposure to other viral communicable diseases. Now, for screening purposes, and this is big, for asymptomatic individuals being screened for COVID-19 and there is no exposure, no sign, no symptoms, and the test results are either unknown or negative, the code to report in those cases is Z11.59, which is used for encounter for screening for other viral diseases. That's the way that it's supposed to be reported according to the official reporting guidelines. And you can see that obviously, see guideline D. That's in the official reporting guidelines of ICD-10, which precedes ICD-10 codes if you have that manual in front of you. So here are the helpful resources that I had mentioned just a little bit earlier on in the program. Blanket waivers, the waivers and flexibilities, what testing codes exist currently for COVID-19, influenza, and RSV. Frequently asked questions for those folks in fee-for-service environment, that covered list of approved telehealth services that, again, Danielle was so, I think it was Danielle, I apologize, but someone had pointed that out just recently that a couple new codes were added to that list just day before yesterday. I wasn't even aware of that. Clarifications with regards to the CR modifier or the DR disaster condition codes. They're just some helpful hints or tools that you may find helpful. These here are resources that I used in order to accumulate some of the data that you saw in the beginning of the presentation, specific to the number of cases around the world and certainly in the United States. So again, you can use these links to go directly to those references that were utilized, in part utilized in an effort for me to put this PowerPoint presentation together for you all here this afternoon. And that basically brings us to the conclusion of what I have for you. Our intention right now is to leave the line open for, at least another 5 minutes so that I can address any questions that may exist. I know that we've got one in here and I'm going to try to get to it right now. Danielle again. All right. So for encounters prior to April 1st, when the COVID specific guidelines became effective, do you suggest reporting Z20828 to symptomatic patients with a negative test result? Danielle, that's a great question. But to be honest with you, if the patient is symptomatic, but they test negative, we're simply not going to report the negative test. What I would suggest is actually reporting what symptom the patient was experiencing and then utilize the Z20.828 as a secondary diagnosis. But I don't think that would be the appropriate primary or principal diagnosis in that case. I'd report the actual sign or symptomology that they have. Can you give me a thumbs up and let me know that that made sense? I'm just looking here in the chat box. I want to see if Danielle responds. Okay, good deal. Are there any other questions that anyone may have? Like I said, I'm going to keep my eyes on this chat box for the next, 5 minutes or so. But in the meantime, I'm just going to give you a couple of things here to run with. First, I say stay safe and well informed. There's a whole lot of folks out there trying to give people information to the best of their ability during these strange times. We at Arch Pro Coding go out of our way each and every day to try to give our clients the most timely and useful information as it relates to everything, not just COVID-19 related matters, but we actually are the only company in the entire country that focuses our efforts on FQHCs, RHCs, and critical access hospitals exclusively. We're the only company in the country that actually offers coding and billing certification exams that are specific to RACs, FQHCs, and critical access hospitals. I urge you strongly to go and check out our Facebook page. Go and like us there. And here's a little carrot in front of your nose I'll put there to make you do it. You can all go and like our Facebook page, and when you do, sometimes we kind of randomly pick people where I know Julia Scott, who's listening in here, she oftentimes likes to, we give away Visa gift cards. Sometimes we like to give, a free webinar away or a 2-hour CEU program or what have you. We really want people to like us on Facebook so we can keep you informed that way as well. It's a great platform for us to use to basically share information as it comes out. And quite frankly, as many of you know, during the time that we've been, that I've been here running my mouth with you over the past, best part of an hour, something may very well have changed today. I mean, these things continue to change at a pretty rapid pace, and that's one of the platforms we use to make sure that we keep our clients informed. If there is absolutely anything that we can do for any of you moving forward, please don't hesitate to ask. Again, my name is John Burns. I hope that you found this helpful. Definitely look forward to catching up with you on the flip side when the world gets back to something close to normal. But until then, stay safe, stay well. Thanks for being with us this afternoon. And if you need me, you can get me at jburns@archprocoding.com. Thanks once again, and have a great day.